Hello, everyone. I'm Dr. Suman Tandon, Clinical Assistant Professor in Cardiology at NYU School of Medicine and Bellevue Hospital. It is my pleasure to introduce my co-interviewer, Dr. Mrinali Shetty, who is an Advanced Imaging Fellow at Columbia University Irving Medical Center. We are absolutely delighted to be talking with Dr. Gary Heller about important points to remember when assessing coronary flow reserve on PET imaging. Dr. Heller is a consultant in nuclear cardiology. He's the past president of the American Society of Nuclear Cardiology, past president of IAC, past cardiovascular fellowship program director, past director of nuclear cardiology, both SPECT and PET, past professor of medicine at the University of Connecticut School of Medicine. Welcome, Dr. Heller.
Thank you. It seems a lot of past, doesn't it? Just to give you a perspective, by the way, this is one of my favorite subjects. And part of the reason is that I began a cardiac PET program at Hartford Hospital literally 20 years ago. We started doing blood flow about 2 years after establishment of the program. But we never reported it for over 10 years. And I think if you talk to a lot of the sort of founders of PET and things like that, it took a long time to sort out what we now know and the clinical applications. So for me, it's a pleasure to see how much PET and blood flow has developed, and we can have a whole session on this topic.
Thank you. Dr. Heller, in which clinical situations does quantification of blood flow add value over relative perfusion assessment?
The simple answer is every patient who comes through a cardiac PET laboratory. Part of the reason I say that is that we find various categories in which blood flow helps, but one of the absolute measures is, did vasodilation occur? And that is a question for both patients with known or suspected coronary disease. You can then separate patient groups into those who already have known coronary disease, the value there, and it is considerable, but I don't want to go into great categories of that. And then those patients with no known coronary disease. I do think there may be a little more value in those patients with no known coronary disease, because a patient who has normal perfusion and normal blood flow has a very high negative predictive value for the presence of coronary disease and coronary related events. So those patients, I think, are going to benefit. Patients who have known disease, it's a little trickier, but I find extreme value. So the answer is, and I think CMS would agree with me because there's a billing code for this and they don't categorize it. So the point is, every patient who comes through, you'll find some value in myocardial blood flow assessment.
Thank you, Dr. Heller. That was very helpful. I agree. Dr. Shetty?
Thanks, Dr. Tandon. Dr. Heller, just to take a step back, could you walk us through the aspects a reader should look at while going through the quality control of a study prior to reading it?
Well, that's a little more complicated, and I must say that it depends on the software that you're using. Also, whether it's a net retention model or a single compartment model. So I can't, you really have to work with the software companies. But what is important is making sure that the placement of the cursor at the start of blood flow assessment, which is either the left atrium or the left ventricle, is accurate. Whether the data collection is accurate, this is even more true for the single compartment models such as motion. And then I think finally looking at the curves that come out at both rest and stress. So all of these assessments are extremely important. The other thing that I think people lose sight of is that looking at resting myocardial blood flow is a critical issue. So in other words, don't jump to the myocardial blood flow reserve data, look at stress, and then finally blood flow. I believe Dr. Dobala will cover this in more detail in the next presentation. So it's quality control, just like quality control with PET perfusion is very important, but software dependent.
Great. I think there are some excellent points there. Over to you, Dr. Tandon.
So, Dr. Heller, what are some clinical scenarios where there are discordant findings, like the perfusion images are normal, but the myocardial blood flow reserve is abnormal?
Yeah, well, this is actually a very important topic, and I would somewhat challenge the question that is discordant because it's not. And I think that's one of the reasons why we're doing blood flow is we get different pieces of information. And a patient who, if you go back to the era where we're not doing blood flow, we know that patients who have normal perfusion have coronary disease. The sensitivity is 92%. So we're missing something. And what we're missing is pretty important, such as three vessel left main disease. And also we're introducing a new topic of patients who have microvascular angina, which can be identified with myocardial blood flow reserve. And the bucket that they're in is in normal perfusion and abnormal blood flow. So if you can, I'm going to bring up a slide that augments that sort of information. So this is a table that was published in the Journal of Nuclear Medicine, Nuclear Cardiology and Journal of Nuclear Medicine about a year ago, in which the authors attempted to classify patients. And this is based upon blood flow. And the reason I'm bringing this up is that if you have normal perfusion and normal blood flow, then your outcome is very good. But here's a patient who has mildly abnormal blood flow, and in fact, we don't consider that study normal. This can be due to either epicardial or microvascular coronary artery disease. So both of these are categories of coronary artery disease, and we don't know which one of those categories they have. Now, you also notice that this is in the range of 1.7 to 2. I'm going to find a pointer here. And so that's what we think is mildly abnormal, but it's abnormal. The second category is more severely abnormal, and that carries an even higher risk of cardiovascular-related events. Normal perfusion in these settings doesn't exclude coronary disease. In these categories of mildly abnormal, the data suggests there's a higher likelihood of microvascular disease. So if you cath this patient, you're not going to find anything, but don't disregard the data. This is particularly true in patients who have low calcium scores. This group of patients, 1.2 to 1.69, has a higher risk of epicardial coronary disease, particularly in the setting of abnormal calcium, particularly those with high calcium scores. So I think one of the real benefits now of blood flow is it's telling you different pieces of information that goes beyond perfusion. So with that, we think you are not excluding coronary disease if blood flow is abnormal. It's not discordant, it's a different set of information. So does that answer the question?
Yes, Dr. Heller, that was very helpful.
So I will say, by the way, this is what we struggled with the 10 years that no one was recording this. And it's only in the last few years in which we've gotten large enough data sets to really examine this more thoroughly that this sort of information has come out. And now we all feel comfortable reporting the data, and it works.
To piggyback off that last question, Dr. Heller, what's the differential when one sees a lack of augmentation when you go from rest to stress flows?
Yes, that's also a very important question. Remember in the introduction, what I said is that this is very important. Every patient who comes through the laboratory, regardless of known or suspected coronary disease. And so it's a measure of whether the patient actually had successful vasodilation, with an exception, and I'll show you that in just a moment. So if you look at this category, at the bottom, it says less than 1.2, which we consider no change between rest and stress. We consider this to be a non-diagnostic study, and you have to pursue, did this patient consume caffeine in the morning? Was there some other thing that's interfering with vasodilation? And we termed this table termed this intermediate. What it means is that you don't know if the patient has coronary disease or not. And what you're doing is you're looking at two rest studies. You're looking at rest perfusion, and instead of stress, you're looking at rest perfusion again. So you need to either repeat that study if you can identify the patient consumed caffeine, or move on to some other imaging modality. And the data clearly show that some of those patients have coronary disease, and sometimes very severe. But there's this other category in which there's no increase in blood flow, but perfusion is abnormal. So that seems counterintuitive, but what we think is happening is the patient has been maximally vasodilated, and the only thing you're doing is dilating the periphery, but you've created ischemia, and the patient has a reversible defect. That is a marker of actually the highest risk category. And I personally, when I see that, even if it's single vessel ischemia, I recommend catheterization. Oftentimes, those patients have very severe coronary disease. So it really is in the context of normal perfusion, abnormal perfusion, and you handle it very differently. This patient does not need a repeat. They need to go to the cath lab and find out what's going on. So these are some of the nuances that have now been elucidated, and I think are very important. It's a great question.
Thank you, Dr. Heller. Some very high yield points there.
Dr. Heller, on the same lines, if you could tell us a little more about how to interpret the global myocardial blood flow reserve values, and how does it correlate with risk?
That's another important question. So I'll stay kind of with this slide and then move to the next one. So the first thing is that we generally accept normal to be flow reserve of 2 or greater, 2.0 or greater. And the interesting thing about that is that it crosses all of the software packages. In other words, if it's a single compartment model, 2.0 is still normal. If it's a net retention model, same thing is true. So that's helpful. It's actually less variable than ejection fraction, which is, as you know, all over the map according to what software package you got. So that's normal. An exception is that elderly, and I'm hesitant to define what's elderly, but what we do know is that blood flow in normal patients diminishes with age. So if you have a patient with a blood flow of, let's say, 1.95 and the patient is 85, then you might give them a pass and say, you know what, I think that's normal. But again, these categories are important. When you go below 1.99 into this range in which you have no dilation, then that is telling you something, and it carries a significance. And it actually correlates with the data. So I'm going to show you the next slide. This is an elegant study by Patel, Bateman, and others in which they examined categories. they had a database of 20,000 patients who underwent PET imaging. Some of you won't do that much PET in your entire lifetime. Dr. Bateman, God love him, has done this, and they published just a fantastic article. Their cut point, by the way, using all sorts of analysis, was 1.8 or less, which they considered abnormal, but they considered it abnormal just because the event rate was different. So here's a patient we talked about earlier, normal perfusion, but abnormal blood flow. And it again confirms what I was saying. If your blood flow is also normal, the prognosis is very good. If the blood flow is abnormal, it carries a worse prognosis. I want to circle back to global flow reserve, because a good 90% of the literature is based upon global data. And I'm sure all of us have seen patients who have normal flow reserve, but abnormal regional blood flow. And that's at a different level. So I'm talking more globally than what I just mentioned. So look at ischemia. Here's a patient with mild ischemia, and even in the presence of normal flow reserve, which may be that category as it's mentioning, their outcome is pretty good and is far worse in those patients who have 1.8 or less. Those patients with, this is the higher risk category. This is greater than 10%. This is mild here, and this is the overall data. So what you can see, though, is those patients who have 0 to 10% and 10% or greater, even with normal flow reserve, have a worse outcome, but clearly having abnormal flow reserve carries a very significant piece of information. So we considered, some authors, by the way, have considered flow reserve as the gatekeeper for intervention. Now, that is not universally accepted, but certainly those with abnormal perfusion and abnormal flow reserve are higher candidates for cardiac catheterization. So I hope that explained it. It's a little more nuanced than that.
Yes, Dr. Heller, that was really helpful. Dr. Shetty?
Dr. Heller, my last question has to do with rate pressure product correction. Could you go over what it is, when do we do it, and if the resting myocardial blood flows are elevated out of proportion to the RPP, what factors should be considered?
Yes, this is also a little complicated, and you'll probably, the interviewers next week or whatever will ask the same question to Dr. Dobala, and they might get a different answer. So this is one of the more confusing parts. So what happens is the resting flow is high. And I showed you in the others, actually we didn't mention it. The normal resting flow is from 0.4 to 1.2. And that we think is driven by rate pressure product. In other words, if the blood pressure and the heart rate are high, it tends to be in the 1.2 range. If those numbers are pretty low, it tends to be in the 0.4 to 0.6 range. But what you're talking about is something in which you calculate the rate pressure product, and blood flow reserve number at rest is even higher. So what do you do with that number? And the next part of that is complicated. So I will personally tell you what I do. Now I use, in the laboratories I work with, we use both single compartment as well as net retention. What I first do is I look at the stress data alone. So I ignore reserve, I go to stress. And we pretty much have a number in mind for what we think is normal increase in blood flow with stress. And if that number is normal and the blood flow at rest is abnormally high, then what I will say is that the data are somewhat discordant, but because of the very high blood flow response at stress, I would consider that to be normal. There are some software packages, particularly in the single compartment model, that will give you a blood flow. They will calculate it on the basis of the heart rate blood pressure product times 1,000 and come out with a number. My problem with that is I've tried to do that and it doesn't always work. So I think the proper response is to identify that there's an issue with the rest data. And you may, in fact, need to repeat that resting study because there's something wrong. The other thing I would emphasize is that oftentimes when I begin working with the lab that's just getting started, the blood flow reserve at rest, the blood flow at rest is often 1.2 or higher. And we calculate the heart rate blood pressure product and it's very high. Well, why did that happen? The reason is you bring a patient into the lab. In the spec lab, you don't care what their blood pressure is. So you start the study right away. In the PET lab, you're measuring resting blood flow. The patient is scared out of their wits because of this big camera, and their blood pressure, heart rate goes sky high, and you end up with a falsely elevated resting heart rate, blood flow result. And so what I work with the technologist is let the patient relax. Make sure you're starting with a normal heart rate and a normal blood pressure, then put them under the camera. When you do that, the number of abnormally high resting flows is much lower. So it's a long-winded response. I think it takes some real thought, and I really rely upon the stress data to help guide me as to whether the whole blood flow response is abnormal.
Fantastic. Thank you, Dr. Heller.
Thank you, Dr. Heller, for sharing your expertise. I think our viewers learned a lot from you about the nuances of coronary flow reserve assessment. Thank you to my co-interviewer, Dr. Shetty. It has been a pleasure to work with you. And to our viewers, please look out for our next webcast, which will feature Dr. Sharmila Dorbala being interviewed by Drs. Jamie Borg and Krishna Patel on the topic of systematic interpretation of a PET stress study. Thank you again.